Hi, Mike Gibson, Greg Stone coming to you live from ACC 2024, and we're talking about the optimal duration of aspirin as part of Dapt. Greg, a lot of studies have looked at this issue. You are looking at just 1 month of Dapt and then stopping the aspirin with Ticagrelor as the anchor here in the ultimate Dapt trial. We keep moving the needle towards shorter and shorter duration, so I'm so excited to hear what you have to say.
Well, thanks, Mike. And you're right. There have been a lot of trials looking at this issue, but many of them have been in chronic coronary syndromes. And in acute coronary syndromes, of course, there's higher risks of myocardial infarction and stent thrombosis that go on for a year or so. And so current guidelines recommend a year of dual antiplatelet therapy, ideally with a potent P2Y12 inhibitor, either ticagrelor or prasugrel, plus aspirin, in patients with a recent acute coronary syndrome. And there have been other studies that have looked at shortening either the DAPT duration by either discontinuing the aspirin or the P2Y12 or de-escalating the P2Y12 inhibitor. Probably the best of these trials, one of the best, was the Twilight study. And that looked at 3 months of ticagrelor monotherapy after PCI, but that was 3 months, and it was in a combination of acute and chronic coronary syndrome. So it wasn't just acute coronary syndromes. There have been two other studies that have looked at shortening DAPT with ticagrelor only, both done from Asia, the TPAS and the TICO trials, but neither of those studies were placebo-controlled, and they weren't all in acute coronary syndromes. So we wanted to really test this therapy in a large-scale placebo-controlled trial of patients with all acute coronary syndromes who underwent successful PCI and were 1 month free after DAPT, and then were randomized to either ticagrelor plus ongoing aspirin, 100 milligrams per day, or ticagrelor plus a matching placebo. And this was the ultimate DAPT trial, of which Xiaolong Chen and I were the co-chairs. And this trial was performed in 58 countries, in China, the UK, Pakistan, and Singapore. So we enrolled a total of 3,400 patients, again, who met these criteria. 60% of them had either a recent STEMI or non-STEMI, for which they underwent PCI. 40% of them were biomarker unstable angina, but with thrombotic lesions, ruptured plaques, or 90% greater stenoses and EKG changes, so real unstable angina. Again, all event-free at 1 month after their successful PCI. So they
Kind of cultivating out people who are a little lower risk, right? I mean,
well, exactly. You've got people who could tolerate both ticagrelor and aspirin open label. So after 1 month. So they tolerated ticagrelor without dyspnea, the most common side effect of ticagrelor, or bleeding. They didn't have recurrent ischemic events. And so that's when we randomized. And that's the right time. Some of the other studies have randomized patients at time 0. And then you end up diluting your subsequent later outcomes by including the equal randomization period early on in the later, dichotomized randomization period. Anyway, so 30 days we randomized the patients, followed them out to 1 year. So it was 11-month follow-up. And we had a primary endpoint of BARC type 2, 3, or 5 bleeding, in which we called that the effectiveness endpoint because we expected a reduction. It was superiority testing, powered for a reduction in bleeding. We also looked at major bleeding, which is BARC 3 or 5, and we also adjudicated bleeding according to the TIMI scale, according to the Gusto scale, and according to the ISTH scale. So we looked at bleeding every which way you can. And then we had a non-inferiority hypothesis for major adverse cardiac or cardiovascular or cerebrovascular events, typical death, myocardial infarction, stroke, repeat revascularization, powered for non-inferiority between the two arms. And that's the real question. I mean, most studies have shown that whenever you get rid of one of the components of dual antiplatelet therapy, you reduce bleeding. But the question is, how safe is it, particularly in hot acute coronary syndrome patients, right? Where we know from 1 month to a year, they have increased rates of MI and stent thrombosis arising both from the treated stented lesion, the culprit lesion, as well as other lesions. So again, the trial was very well done. Patients were well matched. Only one patient was lost to follow-up at 12 months. And the blinding was, again, we showed the patients remained very well blinded. And what we saw was that there was a significant, approximately 50% reduction in bleeding. That's BARC type 2, 3, or 5 bleeding, 55% actually, a reduction from 4.6% in the ticagrelor plus aspirin group to 2.1% in the ticagrelor alone group. And that p-value was less than 0.0001. We saw non-inferiority for MACE between 1 month and 1 year. MACE occurred in 3.6% of patients in the ticagrelor alone arm and 3.7% of patients in the ticagrelor plus aspirin group. So almost identical rates. The p-value for non-inferiority, we had a 2.5% margin, was less than 0.0001. And I think importantly, when you look at the 95% confidence interval, it ranged from a 1.4% absolute reduction in MACE events to as high as a 1.2% increase in MACE events. So with 95% confidence, we can say that, on an absolute scale, that there's very likely to be less than, 1 in 100 difference in MACE between 1 and 12 months with these two strategies. So those are the, and the last thing I'll say, Mike, is that we also reduced major bleeding by all of the bleeding scales. So not just bleeding, including BARC2, which is clinically relevant, but not major, but BARC3 or 5, TIMI major or minor, Gusto, moderate, severe or life-threatening, and ISTH major bleeding were all significantly reduced. And all of those bleeding scales have been correlated with subsequent mortality.
Yes. Well, thanks, Greg. That was going to be my next question. So all types of bleeding were reduced, the mild ones and the severe ones. And thank you for being intellectually honest about the non-inferiority margins. Often when your efficacy event rate is low, it's easy to declare non-inferiority with an absolute margin, but you did it the honest way by saying, let's look at the relative reduction. And you also, gave us I think the honest interpretation. It could be up to 1.2% worse, but, we can't exclude anything below that. Amazing. So Greg, I've reduced the duration of aspirin and people talk about it, but why aren't more people really reducing the duration of aspirin after ACS?
Well, it's multifactorial. As you know, it takes a long time to get new evidence translated into practice. It really helps when the guidelines change. And the guidelines, which were very appropriate at the time they came out years ago, with 1 year of Dapt in patients with acute coronary syndromes, based on studies like Triton and Plato, et cetera. We've now got, this would be the 33rd randomized trial that have looked at either, early Dapt discontinuation or Dapt de-escalation, and nearly all of them are positive. They really don't show any harm, and they all show a reduction in bleeding. So, and this trial is very consistent with Twilight saw from 3 months on with ticagrelor monotherapy in their ACS subgroup. It's what global leaders saw, which was unblinded at 1 month with ticagrelor alone in their ACS subgroup, and now in a dedicated trial with ACS. And by the way, the results were extremely consistent in both STEMI, non-STEMI, and unstable angina. We now see that 1 month is fine, and this is contemporary drug-eluting stents. Again, we've got a population who tolerated Dapt and did well for the first month. So as you said, a somewhat lower risk population, and contemporary drug-eluting stents have really reduced the rate of stent thrombosis and therefore stent lesion-related events. And ticagrelor is, I believe, substantially more important than aspirin when you're looking at progressive, atherosclerosis and native lesion plaque ruptures and thrombotic events in untreated vessels. It's much more ADP receptor mediated than it is, thromboxane receptor mediated in terms of platelet activation through those pathways. Same with stent thrombosis. So we can't make any conclusions as to what should happen after 1 year. And maybe there's a role for aspirin in very long-term secondary prevention. Compass, and other trials have suggested that. But at least through this critical 1 year period where we know you need the P2Y12 inhibitor and hopefully a potent P2Y12 inhibitor for patients who don't have, a markedly excess risk of bleeding, stop the aspirin and stop it at 1 month. And I think everything is consistent. It's time for the guidelines to change, and it's time for operators to start picking up that practice.
And to add to that data, Greg, over on the AF stented patient, we see from Augustus that 30 days was the sweet spot as well, where you
Right.
maximize both efficacy and safety. So a very, very consistent message. Well, Greg, I agree. I think the guidelines need to really look at this. We need to updated guidelines. 33 trials should be enough at this point, I would hope. Thanks for sharing, Greg. Always learned so much from you. Thanks for your leadership. Thanks for joining us today. And thanks to all of you for joining us here from ACC 2024.